This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is Cyberknife for Trigeminal Neuralgia. At any time during the presentation, please feel free to enter any questions you may have using the question and answer feature at the bottom of your screen. We'll answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous to protect your privacy. Today's presenter is Dr. Prachi Jain. Over the years, Dr. Jain has developed the necessary skills and knowledge in treating patients with radiation therapy, including gamma knife, brachytherapy, and external beam radiotherapy. Prior to working with New York cancer and blood specialists, Dr. Jain was an associate physician at the University of California, Davis. She also worked as a research and development engineer at Boston Scientific Corporation. Dr. Jain earned her bachelor's degree in chemical and bioengineering at the Massachusetts Institute of Technology and earned her doctorate of medicine at the University of Minnesota Medical School. She completed her residency at Hofstra School of Medicine, serving as chief resident. Dr. Jain then completed her fellowship at Yale New Haven Hospital. She also has numerous peer-reviewed print and online publications. Dr. Jain, you can go ahead and start.
Okay, thank you so much, Emily, for the introduction, and thank you everybody for logging in for today's webinar. I'm very excited to be here. So my talk today will be on Cyberknife radiosurgery for trigeminal neuralgia. I'm going to go into a brief history of Cyberknife and a general overview of the Cyberknife, and then toward the end of the presentation, I will talk more specifically about Cyberknife in the treatment of trigeminal neuralgia. So the Cyberknife was first developed by a neurosurgeon and radiation oncologist at Stanford University. In the first patient was actually treated at Stanford in 1994. It was then approved by the FDA in 2001, and currently, over 16,000 patients have been treated using the Cyberknife worldwide. The Cyberknife is actually very similar to a standard radiation delivery device, which is called a LINAC. What makes it unique is that it's attached to a robotic arm, and this allows the Cyberknife to treat the body. Another benefit of the Cyberknife treatment machine is that there is no need for a patient to be still or in a head frame, as the machine is able to automatically adjust to the movement of the patient or tumor. The treatment itself is pain-free. There's no anesthesia required. And because of the precise targeting, we're able to minimize the exposure to the surrounding tissue. So this picture here is a picture of our actual treatment machine that we have at Mather Hospital. The next image is actually, just for historical reference, the previous treatment machine that we had at Mather. So just a comparison, you can see here on the previous machine that there's not as much freedom of movement. You're only able to go around in a 360-degree circle, whereas the current treatment machine, Emily, if you can go back with just one slide, has a robotic arm that has actually six degrees of freedom in movement. So the applications of the Cyberknife are broad. We can treat tumors or lesions in the brain or outside the brain. Outside the brain, there's many different applications. Some of the ones I've listed here include spine, lung, liver, pancreas, and prostate. Another benefit of the Cyberknife is that it allows us to treat in a fractionated manner, which means over multiple treatments, not just a single day. So this is an example of one of the treatment plans for intracranial or brain lesion. And this kind of delivery is called non-coplanar beam delivery, which is able to conform tightly to the treatment with very little margin, thus not affecting surrounding tissues. The tracking that we use with this machine is a continual image guidance, and it corrects for real-time motion. When we're treating different areas in the body, we do have different tracking mechanisms. In the brain, we track using the skull. With the spine, we can directly track the vertebral bodies. In the lung, we can actually monitor the movement of the tumor with the breathing. And finally, in some areas where there's no structures nearby that we can lock onto, we do place small fiducial markers inside the tumor, which are like little grain, size of a grain of rice, and it's a gold marker typically. So when treating brain lesions, such as those for trigeminal neuralgia, we use on Cyberknife what's called a frameless immobilization. So this is, like you see on the left, a fiberglass mold, which is used to keep the head in the same position. And this is in contrast to what's used in Gamma Knife, which is shown on the right, which is actually a frame that is put through the skin and attached to the skull to track the movement of the head. So for some patients, for most patients, actually, the Cyberknife is a much more comfortable way of delivery of the radiation. So for patients who undergo treatment on the Cyberknife, it involves a whole team of people that help us deliver the treatment in a safe and effective manner. We work with the neurosurgeons, the neurologists, the general surgeons, pulmonologists, medical oncologists. We also work closely with physicians and other staff at the hospital, including the radiologist and interventional radiology, who places the fiducial markers when they are needed. And then, we have a team within the group that, helps us in delivering quality treatments, prompt service, and with judicial patient selection. So now getting into trigeminal neuralgia. Here we can see a distribution of the global usage of Cyberknife for cranial indications, and trigeminal neuralgia actually accounts for up to 10% of these cases. The trigeminal nerve is the sensory supply of the face and motor supply to the muscles of chewing. And this nerve arises from the pons, which is in the brainstem. The sensory ganglion resides in what is called Meckel's cave, and there are 3 divisions of the trigeminal nerve: the ophthalmic, maxillary, and mandibular. This picture here is just a textbook image of the brainstem, which shows where the trigeminal nerve is located, arising from the mid-surface of the pons. It's what's shown in purple, the nerve shown in purple, and it's quite a large, meaty nerve. So it's very well visualized on MRI, which is the next picture here. You can see the trigeminal nerve is what's in black. Along the left, there's an arrow pointing to it, and this, arises from Meckel's cave. This is the sensory distribution of the trigeminal nerve, which went over earlier, the ophthalmic, maxillary, and mandibular branches of the trigeminal nerve we refer to as V1, V2, and V3. So trigeminal neuralgia is characterized by recurrent episodes of a one-sided electrical shock-like pain along one of the distributions of the trigeminal nerve. There can be many triggers for this, including simply just touching the face, brushing the teeth, talking. I've even heard of specific foods that can trigger this pain sensation. Most cases are due to compression of the nerve root within a few millimeters of entry into the pons. The presentation, again, is typically unilateral. Women are affected more than men. The pain is described like a electric shock or stabbing pain. It just lasts a couple of seconds to minutes and can occur many times throughout the day. Some patients who've had this for a long time may have continuous dull pain in between the episodes. Typically, patients don't complain of this waking them up at night, and distributions along the V2 and V3, so hence the middle and lower of the face, are most common. This is just a slide showing the exact diagnostic criteria of trigeminal neuralgia. Again, it's recurring attacks that can last from a fraction of a second to minutes, severe intensity, electric shock-like, shooting, stabbing, or sharp in quality. And at least a patient must have at least 3 attacks precipitated by a, any kind of stimuli to the affected side of the face. So the treatments for trigeminal neuralgia, medications, surgery, which I'll go briefly over, radiosurgery, which is what I'm talking about today. And then again, these are some surgical interventions: radiofrequency ablation, a glycerol rhizotomy, and then this is just for historical reference, a newspaper clipping showing that flannel bags filled with heated salt had been used in the past. So an overview of the management of trigeminal neuralgia. The first line in any patient who presents is always medical management. Pharmacologic treatment is the first line for patients with classic trigeminal neuralgia, and the medicine that is best studied is carbamazepine. It's an anticonvulsant. Going briefly into the surgical management, microvascular decompression requires a craniotomy, which is an incision into the skull, and decompression of the trigeminal nerve from the blood vessel. This of course is a surgery. There's a risk of infection, side effects, and hospital stays, typically 2 to 3 days. Another surgical intervention, which is less invasive, is a radiofrequency rhizotomy, which can be done with glycerol or balloon rhizotomy. And this mechanism of treatment has a likelihood of persistent numbness that is higher than if a surgery is used, or radiosurgery, which is Cyberknife. So next I have just 2 brief slides showing the radiofrequency rhizotomy here, and the next one is a balloon rhizotomy. So radiosurgery for trigeminal neuralgia is primarily performed using either a Cyberknife machine or a gamma knife machine. High-dose radiation beams are precisely aimed along the segment of the trigeminal nerve. In the case, in either situation, gamma knife or Cyberknife, treatment can take up to 1 hour. The mechanism of action for radiosurgery is via axonal degeneration and edema. So this is actually, ablation of the nerve. The advantages of Cyberknife is that it's non-invasive, it's very low risk. The disadvantages is that sometimes there is a slow time to pain relief, approximately 1 month, and there's limited durability of pain response. However, there are situations where we can retreat a patient using Cyberknife and they can have a better pain response. So this table here is a summary of many different studies looking at Cyberknife radiosurgery for trigeminal neuralgia. If you're familiar with radiation, you would notice that the doses given here are very high, ranging from 70 to 90 gray in a single fraction. And the response rate for improvement in pain is also very high, 75 to 92%, which is very good. So the take-homes of Cyberknife treatment for trigeminal neuralgia: up to 80% of patients treated with Cyberknife have significant and lasting pain relief. The most common side effect is facial numbness. Pain relief can be substantially faster than other forms of radiosurgery. Like I said before, the median time is approximately 1 month. And usually the pain control lasts long-term in about 50 to 60% of patients. And again, if needed, we can also repeat the treatment. So just briefly looking at our treatment planning system, this is an example of a patient we treated last year using the Cyberknife at Math Hospital. And, we treated just a segment of the nerve. Like I said before, the dose is very high, between 70 to 90 gray. And she's doing great. She's had excellent relief of her pain. She's able to titrate off of her medications, which can have many side effects. So overall, a very good outcome. So that's all for my talk today. Thank you again for logging in. If you have any questions, please feel free to email me. I think we have a Q&A section also where you can ask questions. We can take a couple of minutes to go over that. Thank you again.
That's great. Thank you so much, Dr. Jane, for that extremely informative presentation. Like she said, if you do have any questions, there is a Q&A box at the bottom of your screen. You'll be able to enter any questions you may have in there. And all questions are anonymous to protect your privacy. So if you'd like to enter those right now, you can, and we'll read them out loud so Dr. Jane can answer them. Otherwise, if you'd prefer to email her, we can do that as well. We'll just give it a minute, Dr. Jane, for any questions that may come up, okay? We'll give it a couple more seconds. All right, Dr. Jane, looks up. Okay, we actually have one right here. If I had an unsuccessful gamma knife procedure once before, what are the chances it would work again?
This is really handled on a case-by-case basis, but like I said, we've had good experience in retreatment. The gamma knife procedure and Cyberknife are very similar. So I think if you had good improvement with the Gamma Knife, trying again with either modality, you would probably have, it's hard to give an exact number, but you have a good chance at improvement.
Okay, great. We also have one more here. How has the Gamma Knife evolved over the past few years?
So I think, maybe they were referring to Cyberknife, but
Yeah, let's go with that.
yeah, so the Cyberknife, in terms of the preciseness in which we're able to deliver the treatment, it's within a millimeter tolerance. And over the years, it's just gotten better in terms of how accurately we're able to deliver the treatment and visualize the nerve.
Okay, great. So that looks like all of the questions we have for right now. We just want to thank everybody for joining us today. If you have any further questions, feel free to write them in right now before we log off, or you can email Dr. Jane, or we also have a Mather Hospital email that you can, email us with any questions related to our HealthyU webinars. That's matherhospital@northwell.edu. And we can always reach out to Dr. Jane to have that question answered because she is incredibly busy. We have one more question here. If original Gamma did not show improvement, should I consider Cyberknife?
Yeah, I think it's pretty much similar to the first question, but yeah, we'd be happy to set up a consultation and go over, on a case-by-case basis.
Great. I should have actually supplied that number for you guys, the Cyberknife number. I can grab that for you right now. But I did just want to say that when you guys exit the webinar, there will be a short survey for you to complete. If you guys could fill that out, it really helps us to figure out what kind of webinars we will be doing in the future. So if anybody did want to call, Cyberknife in Port Jefferson, where you could speak more about whether or not Cyberknife is right for you, you could call 631-675-5399, 631-675-5399, and they'll be able to help you out there. We'll give it one more second to see if any other questions come up. Those are all great questions. I'm glad that Dr. Jane is able to provide some insight for us. And it looks like we're all set to go. So I hope everybody enjoys the rest of their day. Like I said, if you'd like to email us, it's matherhospital@northwell.edu, or you could call Cyberknife. And if you'd like to see previous HealthyU webinar content, you could go to www.matherhospital.org/HealthyU. Thanks, Dr. Jane, for joining us.
Okay, thank you, everyone. Have a great day.